Hello and welcome back to the Finding Hope with Overcoming MS webinar series. We're back with season 4 and we're so pleased to be back and bringing you an extended session with Dr Aaron Boster from the Boster Centre for MS. My name's Sian Southwood and I'm the head of programmes here, joining you from London in the UK. In a moment, I shall be welcoming Dr Boster and my co-host Liz Waters to the stage for our very popular interactive session today. But before I do that, I just want to run through a bit of housekeeping to keep everything running as smoothly as possible for you. Just a note to say that we are recording the session tonight and you will receive a link to watch that back in the next few days. You'll also note that because this is a webinar, there isn't an audio or video component for our participants, our attendees. However, it is interactive and you are very welcome to use the Q&A tab at the bottom of your screen to ask Dr Boster your questions. If you are experiencing any technical glitches, hopefully you won't, but try leaving the webinar and then joining, and we recommend using a Chrome browser. We try to make the session accessible as possible, so there are what look like subtitles at the bottom of your screen. If you click on the 3 dots, there is the option to mute those. As you exit our webinar, there will of course be a short survey that will pop up. And it would just ask you some feedback, and it really helps us to shape sessions going forward. It is an extended session. We've listened to your request. We know that these sessions with Dr Boster are so popular and we never have enough time to get through all your great questions. So we are going to be running until 8 o'clock UK time tonight. We have had some questions that have been submitted already, so we're hoping to get through those first, just to allow you to settle in and think about what question you'd like to ask Aaron. Now, without further ado, I'd like to welcome Dr Aaron Boster to the stage and my colleague Liz Waters, who will be helping me field some of the questions for tonight. Hi, Aaron.
Howdy. So nice to be back with you.
I know, it's great. It feels like quite a long time, actually, I think, because I didn't do the last one, but we've got Liz here as well. How are you tonight?
Hello.
Hi,
It's
Liz.
a great day.
How are you, Aaron?
Doing wonderful, thank you.
Good, good. What time is it where you are and where are you joining us today?
It's 13:30 here in the Midwestern United States. I'm in Ohio.
Wonderful. And well, thank you so much also for agreeing to do an extended session with us.
I'm looking forward to it.
Back.
I may have to run to the bathroom halfway through. I hope not, but we'll see.
Let's see how we get on. I'm sure we're all sharing that. As we said, we're going to alternate between Liz and I. We'll take a few questions each. And yeah, you know, just take your time. And yeah, so we'll make a start. So Liz, can we ask Aaron, for those people that haven't had the pleasure of joining one of your webinars, can you just tell us a little bit about yourself, and then we'll move into Q&A. So those that don't know you, it'd be lovely to have
an pleasure. So my name's Aaron Boster. I'm a multiple sclerosis neurologist in central Ohio, here in the Midwestern United States. I decided to be an MS doc when I was 12, not because my Uncle Mark had MS, but because I watched my family frustrated and not able to contact my uncle's care providers. And so I promised my mother at that age that I was going to learn to do it better. And I've had a rather directed course through my education and through my career, almost mission driven, with the goal of trying to help people impacted by MS live their very best life. This organization, Overcoming MS, is very near and dear to my heart because many of my treatment philosophies that I've developed and cultivated over the last 20 years are absolutely in line with the 7 tenets of Overcoming MS. I run the Boster Center for Multiple Sclerosis, which is a standalone MS center in Columbus, Ohio, where we care for roughly 1,400 families with MS. I'm very proud to bring a very robust clinical trials program, and really it's an honor to get to care for families here in my hometown. So it's super great to be with you, and I'm looking forward to these questions.
Great, thank you so much, Aaron. And yeah, we'll get into it then. So Liz, we're going to start with you, please.
Fabulous. Hi, Aaron. Thanks so much for being with us.
Howdy.
So if someone has multiple and innumerable lesions on brain and spinal cord and is still functional, but slowly declining, for example, increased fatigue, heat sensitivity and cog-fog, but still classed as relapsing remitting, should consideration be given to a less stressful job and stronger DMD?
So that's an excellent question, which touches on the fact that the situations are complex and multiple factors can influence what's going on. So I really would like to divide the question in half and talk about psychosocial stressors and then also disease modification, because I think that we can kind of address them in parallel. Nobody goes home at night and says, "Hey, honey, let's get stressed out." So that's not a discussion over dinner. And I hate it when clinicians say, things like, "Oh, we'll just remove the stress," as if you could like surgically cut it out. The sheer fact that we're having this webinar during an ongoing global viral pandemic defines a stressful time in everyone's life. So anything that we can do to manage stress is super smart. Both Overcoming MS and the Boster Center for MS embrace mindfulness as a key element in living your best life despite MS. And I think that's based, in the idea that that we have to address these psychosocial stressors. Otherwise, they can make our disease worse. Should you step away from a stressful job to a less stressful job? I don't know. I don't know the income. I don't know the financial ramifications to the family. I don't know the accommodations that could be accomplished. But what I hear is, could I game out my work environment where I spend half my day so that I can function better, so that I have more energy reserved at the end of my day or what have you? So that's worth exploring whether you leave that job or not. Likewise, we can turn our attention at the same time to disease modification. And what I'm told is that you have neurological symptoms, fatigue being the most common MS symptom. And at least in the United States, the leading cause of loss of work amongst people with MS. So I take a very important symptom to game out. And innumerable lesions, brain and spinal cord, which would suggest a higher risk of worsening disease. So for all those reasons, I would want to place that person on the most effective disease modifying therapy that they're comfortable taking. Now, I've crafted that sentence very carefully. The most effective DMT that they're comfortable taking. But I wouldn't want to leave anything on the table because I would want to bring everything to bear. And I think that's a very, very good real world question. Thank you for asking it.
And I remember before when we spoke, we were talking about preparation for your visit when you see your clinician. Is that something that you would advise in terms of where somebody feels with their career, if they're feeling really stressed out, that, that's a conversation that they can have with their clinician?
It's a fool who thinks that we can fix MS with just a medicine. And I think if the psychosocial aspects of your life are risking impacting the disease, then it's paramount that we talk about it. If I'll give you an example. Many of my patients work here in Central Ohio in a factory environment where they have to stand at a conveyor or some type of machine and they have to do a repetitive task and it's timed. They can't step away. That can be really, really hard for someone with motor fatigue and heat sensitivity and other neurological symptoms. And so sometimes we can request an accommodation. They don't have to leave their job, but they are given an accommodation where they can wear special shoes, or they're allowed to sit, or they're allowed to step away, things like that. And so oftentimes I can write a medical letter of necessity explaining the medical recommendation for sitting or a break like that. And that can turn an otherwise really scary work environment into something that works much better.
Yeah, so it really brings home that message, as you say, to sort of think very holistically about it.
So important.
Yeah. Brilliant. Thank you, Aaron. So the next question, I'm wondering what Dr. Aaron thinks about the use of hyperbaric oxygen therapy in MS. A lot of people have told me it helps with their symptoms.
I transparently don't know very much about it, having never used it myself with patients. So please take what I'm saying with a grain of salt. I don't have an expertise at all. The data is not compelling to me. When I review the data, I'm not struck by remarkable outcomes. Period. Next paragraph. Anecdotally, I know that there are places that do it. And I would consider hyperbaric oxygen the same way that I consider what I call a complementary medicine, something that I wasn't trained about, which doesn't mean it doesn't work. It just means I wasn't trained about it. So the 3 rules that I apply to those situations are very straightforward. It can't be too expensive. Now, I don't know the cost of entering a hyperbaric chamber, but if it's too expensive, that's not fair because I can't look you in the eyes and promise you that it could work, right? And only an individual family can decide for themselves if something is too expensive or not. The second thing is it can't be known to hurt you. And I'm unaware that a hyperbaric chamber can hurt you. And so that's good. And thirdly, I don't think it should be instead of something that I know works. So if a patient said to me, Dr. B, I'm going to stop my disease-modifying therapy, which I've been responding to, and I'm going to start doing hyperbaric oxygen, I would be concerned about that. Whereas if they said, hey, Dr. B, I'm going to continue the therapy that's been working, and I'm going to add hyperbaric oxygen. In that second situation, I would say, excellent, let me know how it goes. And if it's helpful, tell me about it so I can tell other patients.
Great. So as long as everything else is kind of ticking along and okay.
The goal in my mind is that it's an and, not an or.
Yeah. Fabulous. Thanks, Aaron. Does primary progressive MS have any chance of getting better with stem cell? I'm an operivist, but still have balance and walking issues and wanted to see if I can do any better.
So this is a very hot topic. Stem cell transplantation has gained increasing steam and momentum. The National Health Services in the UK now have a path where people impacted by MS with severe disease can have a stem cell transplant. Here in the United States, where I practice, that's not something that's commercially available through the third-party payer insurances or through American government insurance yet. It's not FDA approved. It is available through research endeavors. And I think that we can't ignore stem cell transplantation. Now, I have done a handful, 4 stem cell transplants in the context of a big research trial that I participated in. And this was many years back, and we were still learning, and the results were kind of plus minus. In my practice currently, I have a handful of patients who have had stem cell transplants, most of them actually out of the United States in Mexico. And one gentleman in particular has primary progressive MS, and without question, he has improved remarkably. However, it's the only time in my career that I've ever seen that. And so I'm being transparently honest that anecdotally, I have seen one person that had a remarkable benefit, which is amazing. But I can't in good faith say, absolutely, for a limited time only, if you sign up now for $9.99, that can be your outcome as well. I still think that it's appropriate to continue to study stem cell transplantation. And I don't think that it's prime time just yet for progressive disease, although I think that we're actually really, really close. Your point is well taken. You have a condition, you're taking the therapy which is currently available for it, and you feel like you're slipping. And I just want to caution you against false hope, because sometimes the claims of stem cell transplantation are almost magical or sexy. You know, you're going to grow 3 feet and you're going to grow wings and fly. And so I do want to temper that. I have seen other patients that have had stem cell transplantation and they've not fared well. And so I think the jury is still out.
Yeah, so still waiting for research to come in. And
I'm not ready to say prime time for folks just yet.
Yeah, okay. Thanks, Aaron. I should be passing on to Sian for the next 3 questions.
Thank you. Aaron, we had a question here, and I do need to put a disclaimer out in terms of any of my pronunciation, as always, but I have tried, so please do correct me. So somebody's asked, what are your thoughts on Tysabri during pregnancy and breastfeeding? In your professional opinion, are there any obvious major risks to the developing child?
So I allow women in my practice to conceive while taking Tysabri. So they can have unprotected intercourse with the goal of becoming pregnant while taking Tysabri infusions. I feel that it is safe to continue Tysabri for the first trimester. However, after the first trimester, when you enter into trimester 2 and 3, if we continue Tysabri, there is a risk of anemia to the baby. And that obviously we want to avoid. I have helped several women and several families conceive in this manner, where they became pregnant on Tysabri and then stopped in the second trimester, and things have gone well. And so I think it's a very viable option. I don't recommend breastfeeding on Tysabri, although transparently it hasn't been an issue for the women because of their own personal decisions. And I really think that it's an evolution in our understanding, our MS neurologist understanding of these medicines. I remember when I was a younger man with hair, that we wouldn't allow a woman to consider conception on an interferon injection or on a Copaxone injection. And in hindsight, I feel so sad that I took women off those drugs so they could conceive, and in some cases had disease activity. Now, we may place someone on one of those medicines to become pregnant. And my preference, because of the high efficacy, is to place someone on Tysabri. So that's my maneuver to become pregnant so that we don't have to take you off of therapy.
Okay, thank you. And what I take from that is my pronunciation is rubbish.
No. I think you did outstanding. You said Tysabri. No, we're okay.
Okay. Okay, moving on. Is there any medication that you would recommend for somebody who uses a wheelchair, has been following the Overcoming MS program for 5 years, but has recently had a stroke, which has been affecting their vision?
So the reality is that question is too complex to give an actual answer on the interwebs. The reason I say that to you is I don't know the type of MS, the duration of the MS. I don't know the history of attacks and the history of new spots, how frequently we've seen those, how long we've been in a chair, the transition from, if there was a transition from walking to cane to walker to chair, I don't know the rate of that transition. I don't know what meds they've been exposed to and how they've responded to those meds. And so those are all elements that go into that answer. Similarly, there's different kinds of strokes. There's strokes that are bleeds, and there's strokes that are ischemic, and the treatments are different for both. The risks afterwards are different for both, and it most certainly can influence medicines. And so this is a situation where we need to recognize the complexity, right? We need to consider the variables. And then it's only through all those variables on the table that this person with their clinician can navigate together to come up with an answer. My guess, and we don't want anybody guessing, but my guess is there is a path where we could do something to treat despite the recent stroke. But again, there's a lot that has to be considered to answer that properly.
Yeah. Okay. Thank you. Thank you for being honest and transparent about that. Okay, the next question then is, do you have any experience of discovering brain cysts on patients' routine MRIs? If so, do they need treatment? This person has said that their latest MRI scan showed they have a small arachnoid cyst in their left cerebral fossa. I hope I've said that right. You
did. You did. So what's a cyst? It's a little bubble, like a bubble of tissue. And so when you do an MRI, you're taking a very, very detailed picture. It's like looking under an extremely sensitive microscope where you can see lots and lots and lots of details of things. And you'll pick up variations in human anatomy, variations in the structures of people's brains. And sometimes people have cysts. There's lots of different cysts that are named, like we've described them in the medical literature, and they're benign. They mean nothing of importance. And we just notice them because we have this really powerful MRI that can see all this stuff. So then the problem becomes, at least in the United States, about 10 years ago, a bunch of hospital administrators thought it was a brilliant idea to transparently show all patients all reports. What they forgot was doctors go to doctor school to learn to interpret the reports. And at doctor school, we learn that the cyst isn't relevant, even though it's listed, even though we can see it, we know that that's not concerning. But when the patient sees the report, doesn't go to doctor school, they just say that there's this cyst and it scares them. And that's not fair to the patient. So whenever you see something in a report that you're not familiar with, I strongly encourage you not to become emotional yet because you don't have enough information or background, but to reach out to your clinic nurse or your clinician or whomever and say, hey, they said there's this Rachne cyst. Does that matter? Because they're going to say, no, it doesn't. Moreover, someone with MS is typically getting an MRI of their brain, at least where I come from, nearly annually. And so if the cyst changed, we would see it. So it's kind of a perfect situation to monitor. So even if I was wrong and the thing was not good for you, we would check, we would be seeing that it was changing. And so I think that there's an easy opportunity to scare oneself. I'll give you another extreme example. Sometimes a radiologist is reading an MRI of the brain and they'll say something to the effect of, looks like MS, can't rule out lymphoma. Well, I know it doesn't look like lymphoma, and I know the patient has no signs or symptoms of lymphoma. The radiologist in the litigious American Society was covering his or her tush, by listing that they didn't miss it. But the patient who doesn't go to doctor school reads that and they think it says, I have lymphoma, which they don't. So again, no, I don't think that's concerning at all. I just think we need to ask the clinician for some clarification.
Yeah, so it's another conversation, isn't it?
Correct.
Okay, thank you. Liz?
Sorry, my buttons aren't working very quickly. So I've been taking beta seron since 1994. I've had no change on MRI since 2012. But I'm slowly getting worse with slight left leg weakness. I'm 65 years old. Should I be on a newer medication?
So this is a good description of someone who has not been having attacks, but they are having what I refer to as Impera, or progression independent from relapse activity. And beta seron isn't good at slowing that down. Beta seron is pretty good at decreasing attacks, but it's not very good at slowing down disability progression. So in groups of humans, there are medicines that are better at it. Transparently, we haven't tested 65-year-olds. So what do you do with that? Well, what I do with that is I put them on those medicines. So this is someone that I would use a medicine like a B-cell depleter on, because I think that the data for slowing progression is better in those medicines than with beta seron. I do think that there's a trap where you could say, well, I've reached X birthday, therefore I'm done with getting worse, or treatments can't help me any longer. And that's a falsehood in my strong opinion. And so I do think it's important to continue to treat. And I do think that we could probably do better than beta seron in that state.
And how would we go about those conversations? What would that appointment look like, having that conversation?
It depends on geography. It really does, because the system that a person with MS in Great Britain uses is very different than the system used in Canada. And it's very different than the system used in Australia. And it's really, really, really different than the system that we use here in the United States. And so I can have a conversation with you, for example, hypothetically, about what I might do. But I hesitate to do that, quite honestly. We have an international audience, and I don't want to risk giving out some type of Aaron Boster algorithm, which simply is not available or appropriate in that system. Yeah. The punchline here is a conversation with your clinician. And that conversation might sound like this. Hey, clinician, thanks for giving me this beta seron, and I'm really happy that I haven't had attacks, and I'm really happy that my MRI hasn't gotten worse, but I have progression without that stuff, and I'm concerned about that. Could we discuss a different medicine for me, please? That's how I would approach it.
Fabulous. Thank you. What would be the optimal washout period for a patient who is JC positive to change from Tysabri to Ocrevus?
Lovely question. So I don't think that we should do a washout at all. Zero washout. The reason I don't want to do a washout is a couplefold. One, when you stop Tysabri, if you wait 3 months, which is about the time you might need to get it completely out of your body, you have a risk of a rebound, which is a very nasty experience where you have sort of multiple enhancing lesions in a multifocal attack that oftentimes will land the patient in the hospital. It's very severe. And so we want to avoid that. So I've fallen out of using a washout with Tysabri at all. Now, the concern and the rationale originally for a washout was a risk of PML. And so in the United States, most commonly, the way that we make a transition is we may stop Tysabri and check an MRI brain. And if the MRI brain doesn't show the trappings of PML, then we have a confidence as we start Ocrevus. And we do that as a 1-2 punch. So Tysabri January 1st, Ocrevus February 1st, with an MRI in between as a safety maneuver. Now, many of my colleagues who practice MS neurology in Great Britain, they will add a lumbar puncture. And that's even more a better way of checking, because they can look and see if there's JC virus, that's what causes PML, in the spinal fluid. So if they check and see no JC virus, they know with profound certainty that that's not a risk. Now, a lot of American MS patients are disinclined to allow a second lumbar puncture or a lumbar puncture at all. And so I don't see a lot of Americans doing that, but those are the two ways that you can navigate safely. I have transitioned many people from Tysabri to Ocrevus with an MRI in between, and I do it as tightly as possible.
Excellent, thank you. As somebody living with MS, what do you recommend for dealing with vertigo? Somebody says, I suffer from dizziness or vertigo on a daily basis.
Vertigo is a terrible experience. We define vertigo in neurology as a hallucination of spinning. Like, so you're spinning or the room is spinning. And it's oftentimes associated with falling. It's associated with nausea. Very unpleasant. And it can destroy the quality of your life. The inner ears have all of this circuitry to like balance where you are in space. And if they become affected, it can cause vertigo. Moreover, vertigo can be very hard to treat. There isn't a fancy pants pill, which is excellent at knocking out vertigo the way that we can knock out, say, other symptoms like neuropathic pain. The best way of dealing with vertigo, and it is rather successful, is called vestibular physical therapy. So these are physical therapists who have gone to do extra training in neurosciences, and they have expertise in dizzy. And so they are masters of dizzy. And I have seen them shepherd patients back into the road to Wellville. And so when I have vertigo with a patient, that's what I want to start with. There are some medicines that can be adjusted, but I would say the biggest bang for the buck is to go to the physical therapist.
Right. Okay. Thank you for that. Back to Sean.
Thank you.
Thanks, Sean.
Aaron, our next question is, I know that Impera is used to improve walking speed, but could it also help with leg stiffness and leg nerve pain? What are the chances of having a seizure whilst on this medication if I've never had a seizure before?
So it's a lovely question, and it's reflective of the community of people with MS that participate in overcoming MS. This is a very intelligent, multi-layered question. I love it. And it also suggests someone is extremely insightful in their own body because they've identified something which is a truism. Impera is not a pill to help with walking speed. That's how we tested it. Impera is a pill that helps buttress against motor fatigue and heat sensitivity. So different humans with MS can have different kinds of heat sensitive problems. For example, some people who have had an optic neuritis, which has recovered, when they get overheated, they lose vision in their eye and they can't see again until their body cools down. And when those people take Impera, that goes away. And so could someone have an improvement to spasticity with Impera? Absolutely. I've seen that many times. But I would like to share my favorite Impera surprise story. This was shortly after the drug came out in the United States branded, and I had started a patient of mine on it. And he doesn't ambulate on his own, so he uses a wheelchair for ambulation. But at the time, he could stand and pivot and transfer. And we were doing it because we were trying to help his core stability and help with the little bit of walking that he was able to do. And I had put him on it, and this was a follow-up visit. I had forgot to ask about it. So we're talking about a bunch of other things. And as we're finishing the visit, literally hand on the door, the patient's wife says, "Hey, you forgot to ask about the Impera." I said, "Oh, you're right." And she said, "Simply put, you may never, ever remove his Impera," which I thought was a strange answer. And I looked at him and he just smiled, and she smiled. And I said, "I don't understand." And she said, "Allow me to repeat, you may never, ever remove his Impera." It was a sexual thing. He had heat-induced erectile dysfunction. So when his body got overheated during intercourse, he lost his ability to maintain an erection, which was profoundly frustrating and something that they weren't comfortable talking about. But with Impera, he is, quote, "like he's 18 again," end quote, a quote from his wife. And it has improved the quality of their life in a way that is just amazing. So yes, Impera can do all kinds of things that are heat-induced, and I love that. And I love the fact that you picked up on that by your own personal experience. Now, the second question is also very important. Impera was invented not as a medicine for people with MS, but as pigeon poison to kill pigeons. Wow. Sprinkle it on rooftops, pigeons eat it, they seize and die, right? And so in the same way that Coumadin was rat poisoning, and if you use a small amount, it thins a human's blood, Impera can help stabilize neurons in a very interesting way if you use a low enough dose. But if the dose goes too high, a human can seize. Mm-hmm. And that's why we can't go beyond 10 milligrams twice a day with the branded Impera, because it would increase the risk. I can share with you anecdotally, I've had patients that did not listen and took it 3 times a day despite my screaming and yelling, and the gentleman seized. It's terrible. Now, the question is, if I don't have a seizure disorder, what's my risk of seizure with Impera? And it's a very low risk. In the trials, if I remember, it increased the risk of seizure by like 1.5%. Please don't quote me on that. I'm off my memory, but it's not a very high risk. And if you don't have any other seizure risk factors, no family history of seizure, no history of penetrating head trauma, and you're not on any other medicines that can lower seizure threshold, like tramadol is a medicine that could lower seizure threshold. Wellbutrin is a medicine that can lower seizure threshold, then I really am very much not concerned.
Thank you. A very concise answer there. And it's lovely to hear anecdotal stuff that's happened. I'm getting all the ones tonight with the medical terms. So here we go.
I think you're doing great.
Is there a medication without side effects to reduce inflammation in the body for people on blood thinners for heart disease? For example, apixaban, or a natural product and foods to avoid that reduce inflammation?
So that's a complex question. And there's a couple different parts to it. So when a immunologist says inflammation, or when a rheumatologist says inflammation, when an MS doctor says inflammation, they have a very, very specific meaning. Now, sometimes in common parlance, we talk about inflammation more generally, like I'm all inflamed today, or my joints are inflamed, or we talk about an anti-inflammatory diet. Those don't all mean the same thing. And so just for starters, I think we have to kind of clarify when you say an anti-inflammatory, I need to know more about like what you mean. Like, are you talking about asthma? That's a type of inflammation. See what I mean? So yeah. That I'm not sure about. Now, let's pretend that you're talking about MS and the inflammation associated with MS, which is part of the MS's pathology. And we want to use a medicine to treat MS. We have to consider what else is going on with the human, whatever else is going on with the human. So if they have HIV and MS, we have to factor both in. In this example, we have a risk of clotting our blood, so we're on blood thinners and MS. And so that's what we have to consider. And it really comes down to understanding drug-drug interactions in pharmacology. I'll give you an example. right now, the world is studying routine tyrosine kinase inhibitors, these BTK inhibitors. These are very, very exciting molecules that are being studied as what might be the next best thing in MS. But they can thin your blood. There's a risk of clotting problems. And so I have a patient with MS who is on one of these trials and he suffered a stroke. And so he's now on a blood thinner, which disallows him from taking the study medicine, because if he combined them, he would have a higher risk of bleeding. Mm-hmm. Now, fortunately, most of the MS medicines don't have any problems like that whatsoever, but that's not the take home. The take home is, in a complex situation like this, we have to look at all the variables. Now, sometimes that involves having a conversation with the stroke doc and the MS doc and the cardiologist and the primary care doctor, everyone putting their heads together so that we can pick the right medicine for that person at that time.
Okay, thank you. Last one for me for now. Does having a general anesthetic or epidural cause more risks for people living with MS? Which option is wiser if there were a choice? But could this worsen somebody's MS?
So neither will worsen MS. So there's an old wives' tale that an epidural might worsen MS, which is not true at all and is now kind of been pushed out of medical lore. There are still probably some anesthesiologists that do, that help with labor and delivery. Maybe some guys that are like 90 that don't know that, but the vast majority of the field has caught up with the fact that it's completely safe for someone with MS to have anesthesia if they need it. Mm-hmm. That stated, sometimes it takes my patients extra long to come out of the anesthesia or to recover from the side effects of anesthesia. It may take them a little more, like a couple more days than the average guy. Mm-hmm. Not that they can't do it. We have to be planful and give an extra day or two to bounce back post-operatively. Now, which procedure is better really gets into what are you having done and why. And so an epidural or a block, they anesthetize you from, say, the waist down, and you're awake. And so the upside there is they don't have to intubate you. They don't have to put a tube in your mouth to breathe for you, and that has risks associated with it. They don't have to bring your consciousness down to sleeping and then bring it back up.
Yeah.
But you have to be awake for whatever that procedure is. And there are some of my patients, because of problems with swallowing, because of the MS, that going to have a surgery becomes more of a problem. And so typically getting ready for the surgery, you'll have consultation visits with the anesthesiologist, and they will make some strong recommendations. Now, sometimes the MS neurologist needs to jump in and have a little bit of a chit chat, but generally speaking, they're going to game out the surgical risk of going under anesthesia. Me personally, and this is just Aaron's opinion, I would like to do the least amount of anesthesia that I'm eligible for to have the procedure done. So if I could have a block, and this is just me, I would rather have a block than go under general.
Yeah. So it really comes back down to the individual, but the anesthetic itself is no heightened risk.
Correct.
Yeah. Okay. Thank you.
Hi, how are we doing? How are you getting on, Aaron?
Dandy like candy. I don't have to go to the bathroom yet, so all is well.
Excellent. Okay. Can certain DNTs, for example, B-cell depleters, have an impact on food allergies like gluten and dairy? And if you can use them, can you still test on these allergies, or could it be that antibodies are suppressed in some way?
I'm not aware of data. Anecdotally, I've not seen that be a problem at all. There's a lot of seasonal allergies in the Midwestern United States because we have all these seasons, we have 4 seasons, and each fluctuation, people sneeze. And I've never seen a problem with my patients on B-cell depleters. If that was a thing, I think I would see it because I have a lot of Ohioans on B-cell depleters, but I'm not aware of data to that effect. Immunologically, they're very different. And even though it sounds like, it's all immunology, what you're doing with MS lymphocytes and B cells is very different than what happens when you have an allergy like hay fever. It's different antibodies, it's different cells in some respects. And so I don't think they should be a problem.
Okay, that's encouraging. The next question. Hi, Dr. Boster. Can you share how your patients who are 5 for 5 do in comparison to those who are not able to manage to do all 5? And which of the 5 are most important?
This person honors me. You're so kind. When I work with families impacted by MS, I want them to be 5 for 5 in their fight against the disease, not dissimilar to the 7 tenets we use in overcoming MS. And so let's go through what it means to me to be 5 for 5 in your fight. So number one in being 5 for 5 is not to smoke stuff, because smoking increases an individual's risk to develop MS. And if you have MS, it speeds up the disease upwards by 50%, which is terrifying. If a child of someone impacted by MS is exposed to even secondhand smoke, it doubles their risk to develop MS. And in fact, there's a much larger conversation behind the first tenet of don't smoke about other cardiovascular risk factors. So if we are not attentive to high blood pressure and high cholesterol and diabetes, et cetera, the brain can age quicker and you can get worse faster in the setting of MS. And so that's the first one, don't smoke stuff. Now, mind you, in 2023, I say don't smoke stuff because there's different kinds of things one can smoke. So for example, one can smoke tobacco and nicotine, one can smoke cannabis. And in both cases, lighting a carbon-based thing on fire and then sucking in the smoke is not in your best interest. So number two, and being 5 for 5, involves supplementing low levels of vitamin D, exactly as we discuss in overcoming MS. And the data is profound that levels lower than 50 increase the risk of a given human to develop MS. And if you have MS, low levels drive the disease faster. Now, I live in Columbus, Ohio, in the Midwestern United States, where there isn't much sun for 7 months out of the year. And it's really cold even when there is sun. And so we don't spend a lot of time outside during those months. And so when I check the average Ohioan's vitamin D, it's typically like 9 or 10, and I need to get it up above 50. And so you could either stand out in full sun for 15 minutes and risk frostbite to your personal private parts, or you could swallow a supplement to get 5,000 international units of D3 each day, which is the typical recommendation. Now, you can get vitamin D3 through fatty fish, but the amount you would have to eat is undoable. So a 3.5 ounce portion of fatty fish like salmon would be about 600 international units. You need 5,000. So, that's a lot of fish. So we do a lot of supplementation here. So behind the discussion of vitamin D is a much bigger discussion about nutrition. Again, very in line with overcoming MS. And so I spend a lot of energy talking with families about nutrition and cleaning up their diets. That's number two. So number three is exercise as part of your lifestyle, another tenet shared with overcoming MS. And I've crafted that sentence very specifically. Exercise as part of your lifestyle. So what does that mean? Exercising as part of a lifestyle means that if you do it, you're not rewarded. There's no reward for doing something as part of your lifestyle. And if you don't do it, there's no punishment. You're not sent to the naughty corner. So for example, I have a lifestyle of brushing my teeth. I don't tweet about it. I don't make YouTube videos about it. I don't even talk about it when I get to work. It's just something I do every morning. And if I happen to forget to brush my teeth before I head off to the office, I'll run upstairs and do it. This is part of my lifestyle. And so I need people impacted by MS to exercise as part of their lifestyle. And it's, in my opinion, the second most effective disease-modifying therapy that exists. Anyone that has participated in overcoming MS has read the testimonials, and many of you have experienced the profound benefits to MS by a commitment to exercise and movement. Number 4, in being 5 for 5, is mindfulness. And so I'm a very strong believer that each one of us needs to practice mindfulness at least for 5 minutes every day. Now, I remind us that the definition of mindfulness is to be in the present moment without prejudice. So being in the present moment, not thinking about what's going to happen tomorrow at the office, not worrying about something that happened in the past, but being in the present moment. So for example, if you're having sex and thinking about tomorrow, you're not being mindful, right? Because you're not thinking about the present moment. You have to be in the moment and thinking about it to be present and mindful. And at least here in the United States, we train people to do the opposite. So in the US, if you can eat a cheeseburger and talk on the cell phone while driving down the freeway, then you're rewarded for being efficient. And that's abominable. And it increases the risk of depression and a bunch of other nasties. And so I'm a big believer in the daily practice of mindfulness. And that could be yoga, meditation, walk in the woods. I'll share with you something that I have fallen in love with doing myself is I do shower meditation. So I have a lifestyle of showering because I don't want my patients to smell me in the office. And after my morning shower, I sit Indian style in my old tub with my eyes closed and I breathe. And at first I was bad at it. Like in my head, I would say, Boster, get up, go to work. Did you finish your notes? But I taught myself to let those thoughts go. And I've gotten to the point where I can just listen to the water and breathe for about 10 minutes. And it's one of the best parts of my day. It refreshes me. And I can't begin to tell you how impressive it is. Number 5, in being 5 for 5 in your fight against MS, is to be on the most effective DMT that you're comfortable taking. Now, for some patients, that's no DMT because they are not comfortable taking one. And you're an adult, you're allowed to make that decision, even if we're not in agreement. But again, I want to work with you to help you figure out the most effective DMT that you're comfortable with. And that's being 5 for 5. Now, in my experience, anecdotally, when my patients adhere to those things, their quality of life skyrockets. They have less attacks, they have slower disability progression, and they have less symptomatic complaints. And if you said, well, Dr. Boster, prove that, I cannot prove that to you because this is my lived experience delivering MS care to families for the last 20 years. But I think it's still a valid lived experience. That was a great question. Thank you. I'll have to mail you a check for asking that question if I can figure out who you are.
And which do you think is the most important of those 5? If you could pick one.
If you could only do one, it would either be not smoking or exercise because of the effect size.
Yeah.
Now, I would immediately start to argue with you and say, why do we only get to do one? We can do and, not or. But I guess if I was pressed, the effect of not smoking and the effect of exercising are huge.
Yeah.
But please don't make me pick one.
Okay, I won't.
Thank you.
Next question. Hi, Dr. Boster. Do you have any recommended strategies to support an overall increased tolerance to heat?
Yes.
Thank you so much.
Yes. So there's a lot of adaptations that we can do. Obviously, as long as there isn't a seizure disorder, trying Impera is a really good idea. And if you're in the 1/3 to half of people impacted by MS that respond, glory be. That'll be a really big deal. So that's one thing. That doesn't work for everyone, unfortunately. And sometimes it's not enough. So then there's a bunch of other things that we can do behaviorally to help. So a cooling vest is a very powerful tool. Now, when I was coming up through the ranks, the only cooling vests that were available looked like these fishing vests or like, commando vests that no fashion forward human would ever wear in public. They're these big bulky things. And they really weren't amenable to like going to work. But they now make cooling vests that you could wear under a t-shirt and no one would know you have them on. They're completely discreet. They last for hours. And there's cooling kerchiefs and cooling hats and the like. And so using a cooling vest to drop your core body temperature is really smart. I have a patient who works in the Middle East where it's really, really hot. And he works in a nuclear power plant, which sounds like a bad joke, except it's actually his job. And it's extremely hot where he works. And so one of our adaptations was Impera, and one of them was a cooling vest. So what else can you do? Well, you can game out the timing of activities. So for example, if you enjoy a promenade, waiting to do that in the middle of the day when the sun is up might be a major, major problem from a heat sensitivity standpoint. Taking that same walk in the morning before the sun's fully up is the recipe for success. Cooling your body by misters. I have patients in the Midwest that will put a mister over their door frame and they can sit in a chair on the mister and they're constantly having convection and evaporation pull heat away from them. So there's other ways like that we can game out. Another thing we can do is budgeting when we go outside and activities that we can do inside and outside, right? And lastly, we can conserve energy during those times when it's really hot out. So whereas I would normally encourage a patient to park at the back of the parking lot to get their steps in. If it's the middle of the day and that's going to sap all your energy so that when you get to the grocery store, you can't shop, that doesn't really work very well, does it? And so that's an example where we would have someone drop us off at the threshold of the grocery store so that you could be successful in your shopping.
Great. So yeah, just making some, like, even in some cases, some small adaptations just make a big difference.
Amen. Those small adaptations can be not small. They can be really big.
Yeah.
And I encourage people listening, if you're trying to game this out, talk to your physiotherapist, talk to your physical therapist, talk to your clinician, because there's a lot of adaptive measures that can make something as frustrating as heat sensitivity palatable.
Great advice. Thanks, Sarah. Thanks, Aaron.
We doing okay, Aaron? We all right?
We're doing great. One last thing about heat sensitivity is exercise in the water. So aquatic therapy keeps you cool because the water wicks away the heat. And so people that would be unsuccessful in jogging, let's say, or cycling because they would get overheated, they could walk in the water or do water aerobics or do like water Zumba, and they're not going to get as overheated. And so that's another way of dealing with heat sensitivity.
Just going back to your 5 for 5, and you talked about DMTs.
Mm-hmm.
There's been a question actually. Somebody asked, when would you recommend somebody commencing or starting their DMTs?
I would start a DMT about 5 to 6 seconds after I confirm that they have MS. Or I might do it as soon as I'm concerned they're at high risk of developing MS. So if you have, for example, God forbid, a clinically isolated syndrome, optic neuritis, and you have 2 spots on your brain, you don't meet criteria for MS necessarily, but you have an 85% chance of having MS. I will place that human being on a medicine and observe them for 5 years, because if they go on to have MS, I've helped them. I've slowed down brain volume loss and brain damage and slowed their disability. If I'm wrong, then I'll apologize later and we can take them off the medicine. But you can't do it too early.
Yeah. Okay, thank you. This one's quite a long one, so yeah.
1 second.
Get settled. Take.
Okay, I'm ready. Hit me.
Okay, so there's been a great deal of publicity about the relationship between the Epstein-Barr virus, so EBV, and MS.
Mm-hmm.
As EBV is prevalent in the population, I feel that it would be highly unusual for anyone with MS not to have the virus, particularly as routine screening for EBV is not part of the diagnosis process. So there is no window for anomalies with this theory to be established under current practice. They're concerned that emphasis on the virus being the cause may prevent research in other areas, such as neck or spinal trauma, as cited as a possible cause. What would be your thoughts on this, Aaron?
Lovely. Again, a very nice question and a very timely question. And so let's talk about what causes MS and EBV and the current focus on it. So the first thing is, this is not new information at all. We have known that EBV was probably involved in the pathogenesis of MS for 20 years plus. What happened recently, which kind of kicked it into the public press, if you will, was a very large study done in the United States with 10 million Americans. That's a very large number, 10 million. It wasn't an MS study. It was a study looking at 10 million folks involved in the Veterans Administration hospital systems, which is a socialized system within the United States. So we can track people, which is great. And what they found was, on those 10 million Americans, 95% had been exposed to mono EBV. So just as the author of your question stated, the majority of people have been exposed to EBV. Here's the thing. There were 800 people in that 10 million that had MS. Of the 800 people with MS, all of them but one had EBV.
Mm-hmm.
Now, the difference is profoundly statistically significant, about 99.99% versus 95%. And that's where that data helps epidemiologically confirm the belief that EBV probably plays a role in the development of MS, right? So the popular press got very excited about that, and it made a lot of news. So what? Well, it's really important because we don't know what exactly causes MS 100% or how to cure it. We don't understand the condition MS completely. Our medicines aren't cures. They're not perfect. There's still a tremendous amount that we need to learn. And this knowledge or this confirmation allows us to ask questions. For example, at present, there is no EBV vaccine. That doesn't exist, but we could make one maybe. So imagine that we come up with an EBV vaccine and we take the vaccine to Finland, where there's an excellent socialized healthcare system, and we immunize every Finn who is born for 3 years, right? Every Finnish infant gets immunized for EBV for 3 years. And then we watch for 30 years. I hypothesize that generation, those 3 years, nobody would have MS. Now, nobody's running out to do that right now, but I use that as an example of where we might go with this kind of information. I want to reassure the person that it's not as if we put all our chips into that basket. And I would not suggest to you that it's the focus of research these days at all. The focus of research is on treatment for progression and gray matter involvement and things like that. That's really where the focus of MS research is, if there's a direction. The focus of MS research is also really diagnostically surrounding biomarkers and blood biomarkers. And so I don't think there's any risk of like us missing the point because we're too caught up in EBV. However, understanding what causes MS and the players only gets us closer to winning. And one day, maybe within my lifetime, we will immunize children against what might later on go and develop into MS.
Thank you. Moving on. Hi, Darren. Hi, Dr. Aaron. Your new name, Darren. Many thanks for your input. I've had my Ocrevus treatment postponed. Oh God, bear with me. As my lymphocyte levels, LYPHOCTE.
Lymphocyte levels.
Thank you.
Those are white blood cells.
Yep, levels were too low. Is this common?
So this gets a little bit nerdy. It's a really good question. So when someone with MS takes a B cell depleting medicine, so that would be like ocrelizumab, or and so that's Ocrevus, or ufatumumab, which is Kesimpta in the United States. There's a medicine, ublituximab, Briumvi, which just got FDA approved here in the United States. Rituximab, Rituxan, these are all B cell depleters. So they're all medicines. When you take them, they knock down your B cells. So what are B cells? Well, they're part of your immune system, and they're part of the cells that are called lymphocytes. So the lymphocytes are some of the white blood cells, and some of those lymphocytes are B cells. So if you deplete B cells, then the lymphocyte number goes down, right? And so you can see that. And if the lymphocyte number goes down too much, there may be a concern of an increased risk of infection. And so sometimes MS neurologists will order lymphocyte levels and look at the level, and then they can have a better sense of if this individual human is at increased risk of an infection. Now, at the end of the day, the rubber meets the road if the person is having recurrent infections. And so if someone has a depressed lymphocyte count or even a depressed IgG level, I may have a more heightened caution and be more cautious if they were to get infected. But if they're not having any infections, I personally am not taking them off the medicine, because we put them on the medicine to slow down their MS. And so if that's working and they're not clinically having attacks, then yay, I'm not going to throw the baby out with the bathwater. However, if someone has a lower lymphocyte count and they are getting infections, that's concerning. And in that person, we may actually have to take them off therapy, or we may have to treat them with a medicine called IVIG in addition to their B cell depleter, so that we can accomplish both goals of keeping them safe from infection and treating their MS.
Thank you.
Hi, Aaron.
Howdy do.
I've got a nice broad one here for you. So somebody
Excellent.
has written, hi, Dr. Aaron, what are your thoughts on diet and MS? There are so many thoughts on it out there.
That is a great question, and extremely appropriate for us today. I think one of the most developed and thoughtful MS diets is the Overcoming MS diet. And I also am a very big believer that nutrition is very, very important in MS. Now, I don't have the exact same belief system as we see in Overcoming MS, but there's tremendous overlap in my recommendations for diet and the Overcoming MS diet. So let's talk through that a little bit. So if you'll help me count to 9, I can go through the 9 things that I typically think about with diet, right? So I'll start with 1. I can remember that one. The first thing that I think we need to be doing with diet is we have to increase the water intake. So we want 100 ounces of water for ladies and 120 ounces of water for gentlemen. And that's a lot of water. Most Americans do not drink enough water, and we're really, really dehydrated. And increasing water probably has one of the quickest, best benefits seen in MS. Energy, mood, spasticity, fatigue, depression. They all get better with water, which is weird. Fatigue, motor fatigue, spasticity. I mean, it's like weird good. Bladder function, bowel function, giddy up.
Just quickly, is there any quick way, obviously apart from the color of your urine, that is a good indicator for you that you're dehydrated?
So if your urine is clean or clear, you're probably doing great. And if it's bright yellow and you're not taking a lot of vitamins, that's not so good. But what I would recommend doing is drinking a glass of water. I don't care about the size right now, with each of 3 meals, and a glass of water between each meal, and you're good. That's what I would recommend doing. Looking at the color of your urine is probably one of the nicest ways of doing it, because that's actually like gonna really hit it. So that's number 1. So we're almost done. We only have 8 more. So the second thing that I want to do after we work on the water is I want to make sure that we're getting adequate vitamin D3. D3 is the vitamin D that we get when the sun hits our skin. So that's the best, that's the most bioavailable, it's the best absorbed. And as I mentioned earlier, eating egg yolks or fatty fish is one way to do it. Going out in full sun in Australia would be a great way to do it. Or here in the Midwest, when there's a lot of cloud cover, we take vitamin D3 pills. Most commonly, I'm giving people 5,000 international units or 50,000 weekly, something like that. And then we can check blood levels to adjust accordingly. So that's number 2. So number 3 is the hardest one, and it's the one that most Americans struggle with. And it's arguably one of the most impactful. And that's to eat whole food, real food, single ingredient food, period. To avoid heavily processed foods, fast foods, sugar-laden foods, fried foods, diet foods, sodas, and foods that have ingredients that you can't pronounce. Because you know all the food words. Like, you're really good at that. Like, if you understand the English, then you know all the food words. Like, you know what chicken is, right? That's a food. But if you look at a word and it's got a bunch of letters and you're not sure how to pronounce it, it's probably not a food. It's a chemical, and I don't want you to eat that. Now, adhering to that diet is expensive, and it's not the way most Americans shop. It changes where and how you shop and stuff. But it's profoundly impactful. And if you do that, I am so delighted, because people run in my office saying, "Oh my gosh," and they're so excited to share, and I'm so excited to receive them, because invariably it improves the quality of their life massively. All right. So that's 1, 2, and 3. So let's get on to number 4 and talk about macronutrients. So I think the most important macronutrient is protein. Overcoming MS recommends a plant-based diet. I don't recommend a plant-based diet, but I think a plant-based diet's a very healthy diet. But whether you're going to be getting your protein source through meat, or whether you're going to get it through vegetarian means, it's still the most important macronutrient. And I'm of the opinion that we want to have 1 gram of protein per kilo of body weight. And so for the Americans listening, that's 1 gram of protein for 2.2 pounds of body weight. And that's a lot of protein. So a lot of guys and gals need to be eating 60, 70, 80 grams of protein a day. And you may be shocked when you count up how much protein you eat, because it might be a very, very small amount. Like for example, a sandwich doesn't have very much protein on it. Like it's a lot of bread and carbs and other stuff. Now, an egg has 6 grams of protein. And so if you need 60 grams of protein, you're either eating 10 eggs or you're doing something else. So getting the protein is very important. And I recommend dividing that across however many meals you eat. So I, as someone who does intermittent fasting, I eat 2 meals each day. And so I need to make sure that I get half my protein in one meal and half my protein in the other. And I actually recommend eating protein first because it's the most satiating macronutrient. And so it's going to fill you up the most. It's going to help with body composition and maintaining a healthy weight despite having MS. So that's number 4, I think. Number 5, we would move on to the macronutrient fat. So fat is not bad for you. American scientists destroyed our understanding of nutrition in the 70s and propagated a bunch of stuff that quite honestly is false. And they demonized fat, which is bad because fat's not bad for you. Now there are healthy fats and unhealthy fats, but the fat is really actually a fantastic and important macronutrient. And there's all kinds of healthy fats like cheeses and avocados and all kinds of delicious things. We're not talking about fried foods here. And I want you to have fat in your meal, and I want you to eat it right after the protein, before any carbohydrates come into factor. Now, and I want you to have fat with each meal. I think it's really important to pair that with your protein. The third macronutrient is the tricky one, and this gets into carbohydrates. So simple carbohydrates should be avoided. I personally have come to believe that sugar is a poison, and I think it should be avoided at all costs. And simple carbohydrates like bread is a sugar. So having lived in France for a while, I fell in love with baguettes. It's one of the most delicious things on the planet, but it just turns into sugar in your body. And so avoiding simple carbohydrates is really, really important. Now, in the world of complex carbohydrates, there's one kind of complex carbohydrate that's extremely important, and that's fiber. Fiber is an indigestible carbohydrate. So like sawdust would be a good example of fiber. You can't break it down. And most grains and things have fiber components in them. And you need to have a lot of fiber in your diet. 38 grams if you're a gentleman, and 25 grams if you're a lady. And that's a lot of fiber. Now, I'm ashamed to admit that most American diets are nearly devoid of fiber, particularly fast food and heavily processed foods, because it makes it take longer to cook and it takes longer to eat. And so they remove the fiber, which is horrible. Fiber is really important for a lot of like colon cancer risk, but it's also really important for gut health. Here's the dealio. There's a bunch of bacteria in your gut, particularly at the end of your gut in the colon, and they help process your food. They eat your food. And in the setting of MS, we have something called dysbiosis, where you have the wrong gut bacteria. And so that can actually cause IBS, constipation. It can cause malabsorption, leaky gut, all kinds of things that are naughty and bad. And you want to make sure that you have good probiotics, and you want to make sure that you feed them fiber. We call that a prebiotic. So fiber, one of the things it does is you can't digest it. And so it gets down to your colon and it's fermented or eaten by the bacteria. And they make these healthy postbiotics, these short chain fatty acids like butyrate, which do a lot of really good things to the gut. And I think actually help MS, believe it or not. So fiber is really, really important. The other thing that fiber does is fiber acts as a sponge. So fiber plus water plus food makes a big bulky stool that's easy to hold on to and easy to pass. And so by taking fiber, we can help combat constipation and IBS, which is all too common in the setting of MS. And so I think we're on like what, number 5 or something?
6, I thought.
6. Yay. Okay.
Unless
great.
unless I've counted one extra.
I'm going to go with 6.
Okay.
So number 6 is the timing of when you eat, not what you eat, but when you eat, because a lot of Americans eat 6 meals a day, which is disgusting. Breakfast, 11sies, lunch, snack, dinner, midnight eating, like literally. And I was guilty of that. But here's the problem. When you eat something, it kicks your insulin up. When insulin is elevated in the blood, that's the storage hormone. So if I eat a bagel, my insulin goes up and my body's being told we have enough energy. Thank you. Anything else that we receive, we're going to store on Aaron's gut or his butt as fat for later. And so if I eat a bagel and then a couple hours later, I eat a Danish, if I'm running while I eat the Danish, I will burn it as energy. But if I'm sitting, it goes on my tush as fat to store for later. Excuse me.
Bless you.
Forgive me. I'm not allergic to fats, but at any rate, so if you finish eating, for the next 6 hours, you will burn glycogen. You'll burn sugars in your body. After 6 hours of burning sugars, you either die because you have no energy sources, or you switch energy sources to fat. And you will burn fat that's called lipolysis. Here's the thing. As long as insulin is elevated, you can't do lipolysis. You can't burn fat. So if you're the average American eating 6 times a day, keeping your insulin level elevated, anything you eat is stored as fat and you can never burn fat. I was doing that. So when you stop eating 6 hours later, you finally tap into lipolysis and you will keep burning fat until you break your fast. So if you are spreading your meals out and not allowing that, you're going to gain weight and have trouble controlling body composition. If you can avoid snacking, you're going to burn fat in between meals. And I, for example, only have 2 meals a day. So I have 16 hours each day that I tap into my fat stores. And as a result, my pants fit. It's awesome. So when you eat matters. Now, 7, 8, and 9, just in the interest of time, gets into supplements beyond the vitamin D, right? And beyond the fiber. I believe that people impacted by MS are well served by taking a probiotic. I do. Now, whether that's sauerkraut and kimchi or natural Greek yogurt, or whether that's taking a probiotic supplement, I think it's a really, really important thing to do. I also am a strong believer in taking omega-3 fatty acids, not dissimilar to the Overcoming MS diet that recommends flaxseed oil or flax seeds. The fiber in flaxseed is fantastic, and the omega-3s are really, really fantastic. And lastly, I do recommend that people take a multivitamin just to make sure they're covering all their bases and they're getting enough micronutrients. And so those are 9 things that I think about when I'm talking about diet with people impacted by MS.
That was an incredible answer, Aaron. Thank you. I feel like I've just learnt a vast amount in about 5-10 minutes. Thank you.
Yay. Good.
Next question. Have you heard of IV ozone therapy working?
Say it again.
IV ozone therapy. Have you heard of that working?
I am not familiar, so I can't comment on it because it's nothing I know about. So I apologize. I'm going to have to pass on that one.
No, not a problem. Next question. I struggle with intractable nausea causing serious weight loss. No one seems to understand what's really causing this, but it happens in tandem with other neurological symptoms, so I feel it must be linked to my MS. Do you have any suggestions for questions that I should be asking doctors to help figure this out and find a way for me to eat?
Yes. So it can be involved in MS. I have seen this before. And there's an area in the base of the brain called the area prostrema. It's part of the medulla oblongata. Just some funny Scrabble words. And if it's impacted by MS or something else, it can cause a problem with nausea and vomiting. So one of the things that I would be curious is when we look at your MRI, whether the medulla has been affected. Because if it has, then you can point at it and say, hey, doc, remember anatomy? Like, that's why I'm throwing up. Now, that's a cold comfort because just because we see that doesn't mean there's something we can do about it. I have seen an acute MS attack of nausea and vomiting, which was improved with steroids. But that was an acute thing. Like it just happened. It was going on for a short period of time. We gave steroids and it got better. And I'm concerned that the way that you're describing this has gone on for some time. And I think, whereas I wouldn't be opposed to a course of steroids to see empirically if it would work, I wouldn't be holding my breath for that. Now, fortunately, there are several things that we can do to help with nausea. My favorite is cannabis. So cannabis has several different benefits in the setting of MS, and one of them is managing nausea. And so there's a FDA-approved synthetic THC product that's been on the market for quite some time, long before medical marijuana was made available, called Marinol, which is FDA-approved for patients with cancer who can't eat because of nausea, because of chemo. And I've used that in the setting of MS with some patients before. I've used it for cachexia. That's a doctor word for you're not eating and you're wasting away. And so we give you a medicine like that, Marinol or cannabis itself, to help increase appetite and increase the ability to eat. I have some patients that really they're only able to eat if they use cannabis. There are other medicines like Zofran is a medicine, ondansetron that I use quite a bit to help with nausea, although those aren't things that I like to keep people on long term. So there definitely are things that we can do to intervene. As my mentor used to like to say, sometimes nature's too generous and you can have MS and then you can actually have a different reason that you have nausea, like diabetes or something. And so, or an endocrine problem. And so it would be important that we don't ignore the rest of the human body while we're trying to treat that.
Yeah, great. But overall, it sounds like there are lots of avenues that can be explored. It's just having that conversation.
Correct.
Yeah, fabulous. Thank you. Hi, Shan.
Hello. Aaron, how would you feel about 3 sort of quick fire questions?
Do it.
Okie dokes. So carrying on with the conversation around cannabis, can medical CBD better MS symptoms? And does it affect the cognitive function for somebody living with MS or their quality of life?
Yes, CBD helps symptoms, including anxiety and insomnia and pain. And no, it does not affect cognition at all.
Thank you. How often would you recommend an MRI to review the number of lesions in the brain and spinal cord?
Once annually with the brain, every other year with the C-spine.
Thank you. For those blessed not to suffer from fatigue, is there a minimum amount of sleep recommended to hopefully stay relapse-free?
I don't know that there's a correlation with the number of hours of sleep, but 8 hours is what most red-blooded humans need. And so I would budget for 8 hours, meaning I'm logging that I have that amount of time I'm able to sleep.
Okay. And then if a person living with MS is diagnosed with fibromyalgia as well, how can they know the pain in the muscles and the spasms that happen aren't from MS? And will baclofen help a person with this kind of pain?
They can't know the difference. And yes, it'll help both.
Thank you. Back to Liz for the last few questions. Then I've got the killer question at the end.
Okay. So we'll do 3 more, Aaron, from me.
Perfect.
And then I'll hand you back to Shan for sort of close it, the big question and closing thoughts. So I'm a bit unclear about the spelling on this one, so I'm going to have a guess of what I think they're saying. Can MS cause bursitis, similar pain in the hip joint? I've been suffering a lot and the rheumatologist disregarded any type of arthritis.
Yes, indirectly. So let's discuss this. Let's pretend that your left leg is weak or wonky, and so you walk with a limp, and it forces you to use the right leg more than you normally would. You're putting undue stress on the good leg, on the good hip and the good knee. And it can cause damage to the knee or the hip joint, and it can cause swelling, which is called bursitis. So the MS causes the good leg to develop joint problems because you're overloading it because of the limp, because of the bad leg.
Yeah, okay. And if somebody is suffering from that, what kind of options are there for treatment?
So the smartest person to help is oftentimes the physical therapist.
Yeah.
And sometimes they may need to educate the well-intended clinician that it really is related. Physical therapy is the best way of addressing it. There are local injections into the bursa to quell inflammation locally, which can help speed up the healing process.
Great. Okay. Should I seek to commence DMT if I'm experiencing increased vertigo and dizziness? Should I request an MRI?
Yes, yes.
Okay, nice and easy. There's another one around heat sensitivity here. So, hi, Aaron. If you have MS heat sensitivity, especially cold hands and feet, yet also overheating at different times, is there anything that could help? I have pins and needles in both hands as well. That is progressing up arms and legs, especially when cold or hot.
So sometimes you can have more than one reason to have ouchie yaya in your hands. You can have neuropathic pain and heat-induced discomfort and spasticity, and it's really not fair, but it's real. One of the things that you can try to do is to try to regulate the temperature of your hands, which involves putting on gloves, taking gloves off. I know that sounds silly, but it's not. So for example, here in the Midwest during the winter, when it's negative, 2 degrees outside, and it's 80 degrees in your house, your hand goes from really cold to really hot. So putting gloves on to keep them hot when you're outside and taking them off when you get inside isn't silly. It actually can help quite a bit. There are neuropathic pain medicines to dampen the intensity of the discomfort. They're not magic, but they can really help take the edge off.
Great. Thank you. Back to you, Sharon.
Well, you whizzed through those questions, didn't you?
I did.
So possibly a couple more, Aaron. Going back to the 5 for 5 about not smoking. Somebody's asked, it's quite specific, is being exposed to wildfire the same? Is that considered to be harmful because they're living in Chile at the moment? Welcome.
It hasn't been studied. I'm not aware of any epidemiologic studies. Ostensibly, it would be a bigger problem. And the reason I say that is because there's a theory that one of the reasons we've seen an increased risk of autoimmunity and MS in specific is because of pollution. And so with increased smog and with decreased air quality, we've seen an increase in incidence of MS. And so it is conceivable that significant exposure to forest fires could be a problem, but I'm not aware of data about it specifically.
Thank you.
That's a good question.
Yeah, and welcome to that person joining us from Chile. It's amazing. Going back to the subject of DMTs, and it's a point that we talked about earlier about starting as soon as MS might be suspected. So the person's asked, are there any risks from starting early? Do we risk impacting their immune system negatively and not helping the body's immune system protect versus against other diseases?
If a doctor ever tells you that a drug doesn't have side effects, leave the office because they're lying. All drugs have side effects. In some MS drugs modulate the immune system. They do not increase risk of infection, but they alter MS outcome. Some drugs, oftentimes more effective drugs, treat MS by suppressing the immune system. And so, yes, they can increase the risk of infection. It's a risk benefit. So there's an American child's author, Dr. Seuss, and he wrote this book called The Lorax. And there's a famous quote that I like. It says, "I am the Lorax that speaks for the trees because the trees have no tongues." And so as an MS doctor, I'm going to take the stance of I want to protect the holiest of holy, the supercomputer that runs the body, the brain, and the superhighway, the spinal cord, because we can't replace it. And so, in my opinion, in the hierarchy of needs, it's really important to keep the supercomputer intact. And we can grapple with the risk of infection or the grapple with other side effects. We have to consider them, but we can work through them. We can mitigate those risks to keep your brain intact.
Thank you. The penultimate question for you, Aaron. Hi, Dr. Aaron. Thanks so much for sharing your wisdom. They were diagnosed in May 22 and they're 33 years old. So they've had no prior symptoms and then had a serious relapse. They're at about 85% now and on the DMD Tecfidera. As it's so early, should they consider an infusion and something stronger instead to try and limit their relapses? They're an essential worker, so they don't want their immune system completely wiped out, but would consider it. What's your thoughts?
I want to bring a SWAT team to a knife fight because I don't want to fight a knife fight. I want 8 guys in front of me that have a name like Biff with muscles on their muscles, with semi-automatic weapons and flak jackets. And I'm going to stand behind them and give MS the bird and fight MS in a knife fight. If Tecfidera holds your disease at bay, that's great. But if it doesn't, you accrue irreversible brain damage. And if you don't want to have irreversible brain damage, which obviously you don't, then you would want, in my opinion, to be on the most effective medicine possible. Tecfidera is not the most effective medicine possible. Tecfidera is a good medicine. It's not a great medicine. If I, Aaron, had the option to upgrade, I would. Like, so for example, this is my cell phone. Now, I had a phone 15 years ago, and I don't have it anymore. It probably would still work, but nobody uses technology from 15 years ago because newer technology brings new things, new benefits. And some of the newer medicines that have come out since 2013, when Tecfidera came out, can do things that Tecfidera could not do. And so My opinion is that I would upgrade. Now that just makes me opinionated. It doesn't make me right, but that's how I would approach it. Thank you.
So this is the question I really wanted to end on, actually. It's quite a long question and a bit like a statement as well. So,
okay.
What advice would you give to somebody who's often feels guilt about their MS? They're very fortunate to say that they're quite healthy and actually would never know that they had MS. But sometimes they feel guilty wearing, we have like sunflower lanyards that people wear in airports or on public transport, because people would look at this lady and say that they're just a healthy 28-year-old, which on the surface of it, she is. What's your thoughts on that statement? She said that MS is truly an invisible illness.
This is an excellent question, and thank you. And I agree with you. This is a very, very important question because the vast majority of MS pathology is invisible to the outside observer, and so oftentimes invisible to even loved ones. And just because something is invisible doesn't mean it's not real. It is real. And to add insult to injury, someone with MS can suffer and then be sort of dismissed by society for thinking they're faking it or that it's not real. And so the way that must make an individual feel is abominable. And so I apologize for being passionate, but this is unfortunately something that people with MS have to deal with all the time. The first thing is, I think it gives us insight into the human condition. You don't know what somebody's dealing with. You don't know if they're being abused at home. You don't know if they've lost a child. You don't know. You don't know if they're not able to pay for food. You don't know if they're dying of cancer. All you know is the outside that you see. And so I think when you have a chronic condition, in my experience, people become nicer with the chronic condition because they become sensitive to the fact that we're not aware of everything that's going on with people right now. We're not aware. And so it behooves us to be a little bit more kind. And yet not everybody is. And so very commonly my patients will hear things like, well, honey, I didn't know you were sick. You look so good. Are you feeling better? I bet you're feeling better, which is so profoundly disrespectful that sometimes we joke about excellent responses. Someone says, oh, honey, you don't look sick. Say, oh, well, you don't look stupid or insensitive, you know, and I say that tongue in cheek. I'm not suggesting that you get in fisticuffs in the streets, but I think at the same time that we work on being kinder to others. There's two other things that we need to do. You are, in my opinion, madam, obligated to wear that lanyard. You are obligated to wear that lanyard because you are the only person that can normalize that behavior. You are the only person that can cause a discussion. Why is she wearing that? I'm wearing it because if I stand up too long, I fall over and I can't feel my legs. I have MS. Yeah. I didn't know. If you hide your illness, you do not allow culture around you to grow and become smarter. I tell people who are embarrassed of their cane, I said, don't you dare be embarrassed of your cane. A cane is a sign of intelligence. A person with a cane would like to not fall. And so when a little boy is walking with mom, it's, mommy, why is she using a cane? That's an opportunity for the mother to say, well, she doesn't want to fall, honey. She has a problem with her leg and the cane helps her and it normalizes it. So then one of the things that we need to do is we need to be brave. I'll remind you of the definition of bravery, doing something despite being scared, right? And going out into public with your lanyard when you look gorgeous and there's no outward problems, it can be scary. And so I want you to be brave, right? The second thing is I want you to be very selfish. You need to be selfish. You live your life one time. And you're not living your life so some stranger you don't know thinks nice, polite things about you. You're living your life because you want to live a full life and you want to provide for your family and be loved and loved. And you don't have time, in my opinion, to worry about what they say. You know, there's a great expression, your opinion of me is none of my concern. And I want you to have that opinion. You're not faking. You have that lanyard because you need it, right? You have that lanyard because you deserve to have it, because your society makes exceptions to help you, right? And so I'm not going to be embarrassed because I have glasses. I love seeing, like I'm a fan. And if I wear glasses, I can see. When I was a little boy, someone called me four eyes. Great. I can see really well with my four eyes. And I know that's a silly example. And I'm not trying to suggest that your situation is the same as my glasses. I just use it as an example where you need to be a little bit selfish. And so that's my opinion. And I really appreciate your willingness to bring it up here on this call. Thank you.
Thank you, Aaron. I just thought it was a really nice sort of question and discussion point actually to finish on, and just really thank you to everybody for their honesty tonight, and their bravery actually posting their questions. But
100%.
And absolutely to you as well. I mean, we've had an hour and a half of you answering questions without even thinking. I'm in awe always at these sessions.
I'm just really glad I didn't have to go to the bathroom. I was really worried.
Take those small wins, right?
Thank you for having me.
No, thank you so much, Aaron. And I hope, I think you're going to be back with us later in the year. And
yeah, I certainly hope so. Until then, you guys can find me on the interwebs. So I make a YouTube video every Monday. You can find me on YouTube at Aaron Boster, MD. Come say hi to me on Twitter, Facebook, or LinkedIn. It's also Aaron Boster, MD. And if you want to check us out, we are taking new patients from around the globe. My clinic, you can find us online at bosterms.com. And so until our next session, thank you guys so very much. It's great to talk to you again. I hope you have a great rest of your weekend.
Aaron, it's been brilliant. Thank you.
Bye-bye.
Bye. That's it for us tonight. I just wanted to thank Aaron so much again. I hope you've enjoyed it as much as we have. Equally, I need to thank my co-host Liz for facilitating the session with me, and Claire, who's in the background, hidden away, who's been fielding your so many questions. But most of all, thanks to Aaron, thanks to our audience. Thank you for your honesty and posting so many great questions there. I think the extended session works so well. We've been able to get through those that have been submitted before and during the session. So we will be sending that link out to you in a few days' time, which you'll be able to watch back the webinar at your own leisure. And we'll be back on the 1st of March for another Ask format session with Sam Josephs, who's our nutritional therapist, talking about the Overcoming MS diet. Thank you so much for joining us on a Saturday evening, Saturday morning, wherever you are joining us. And we hope to see you again soon. Thanks so much.